So there have been a lot of changes for available for treatment options for patients with CLL. I'd say in general we think of patients both in the frontline setting for therapy, so as their first treatment, as well as patients who have had any line of therapy first and then relapse after that first therapy or second or third therapy, or a refractory, so the relapse refractory patients. For frontline treated patients, I think what's changed the most in the past 5 years is we're trying to identify both the patients who may still be both eligible and benefit long-term from chemoimmunotherapy. So we're talking in young, favorable risk, so IGHV mutated, no high risk deletion 11q or deletion 17p, and that those young fit patients with those favorable characteristics sometimes can get very long-term 10 or 12-year plus remissions from frontline FCR chemotherapy. I think there are also patients with favorable risk that might be older, that for a host of other comorbid reasons or whatever it is, that may get meaningful remission from a fixed duration of frontline chemotherapy, such as even bendamustine rituximab, although I don't use BR for the younger patients. But the bigger advances in the frontline, really the only targeted agent currently approved outside of clinical trials for frontline is ibrutinib. And more recently, there was a publication that looked at long-term follow-up of 5 years of a cohort of patients that was mainly frontline. And what we learned is patients that were not high risk, so not 17p or TP53 mutated, and particularly some of the older patients that tolerated ibrutinib, had very, very, very low progression-free survival over the 5 years.